Thank you, Dr. Tarun, for the kind introduction. Uh, uh, you said nicely that when you have a jam-packed program, the timekeeping is also most important. Uh, and so the management of immunosuppression in COVID times. So immunosuppression is a part and parcels of transplantation. It is needed to save the graft, but at the same time, we have to curtail it so that you get less and less more in complications because of the over immunosuppression, because of the CMV, BKV, and other infections. So I'm going to talk in the form of an introduction, considerations for performing a transplant, what immunosuppressions and how it affects the COVID, whether the new transplants are to continue on dialysis, whether what to do it, because earlier people were hesitant to do transplants, but again, and even the guidelines said that hold the living donor transplant and do only deceased donor transplant. What induction therapy, because people are worried about the induction therapy because they're more potent, and what do if the patient, the recipient gets infected, and when to restart the immunosuppression back to normal. So you all know that the consideration in performing a transplant is the uncertainty. We don't know anything about the virus yet. Even though we have 9 months, it is an evolving pathogen, and the mutation has happened in UK, and the severity, X, and duration of the pandemic is also not known. Possibly people are saying 2022 is possibly going to end. So the risk of healthcare associated and the community acquired and the donor-driven infection, till now we didn't have any donor-driven infection, but again, there is still a chance because the kidney harbors the virus and there is urine also showed up a pathogen. So the potential adverse effects of the psychological effects of heightened infection, if you see the newspaper or if you earlier of this year, if you hear any of the news, it was very, very horrible situation. Everybody gets actually psyched after hearing that. So deferring a transplant is availability of the dialysis. Again, it's a problem. Earlier, again, it was a very, very problematic for those who are positive to get a dialysis was difficult, and everybody used to deferred dialysis. Adverse and medical, if the patient is long on dialysis, then more and more diseases and the transmitted infections, and also the psychological problem, more and more DSA, and the poor long-term outcome as compared to the preemptive, we all know, and the burden, economic burden also shoots in. And the infection of the different 19 groups, like a transplant patient, dialysis patient, what is the outcome we didn't know. And now we have some literature, and the treatment is not appropriate. Again, we are using remdesivir nowadays, but again, previously it was a difficulty and what to use and how to go about. Preceding for the transplant, more severe, potentially fulminant disease, it happens immediately after the transplant, then what you do, because that's a heightened immunosuppression, then it's a problem. Therapeutic trials, the purposes of what are the outcome we didn't know, and the risk of drug-drug interaction, the immunosuppression, and whether to reduce the immunosuppression, how safely, and what to reduce was a big question initially. So dialysis patients, they have medical comorbidities, and if you continue to do it, they are also vulnerable as compared, you all know that all these dialysis patients will have a diabetic hypertension, IST, so they are also more prone, and the therapeutic purposes will how to compensate. So immunosuppression is a beneficial effect in an immunosuppression, whether it is beneficial, because most of the patients we are losing because of the cytokine storm. So whether these immunosuppression, they reduce it, we don't know, but they suppress the immunity, and they may have both the innate and also the adaptive immunity may be suppressed, and it may create a problem for COVID too. So innate immunity, which is mediated by the IL-1, 2, 3, 6, and TNF and interferon, are trying to protect the human cells from the virus. You all know that the interferon generation is also blocked by the virus, which increases the multiplication of the virus. So hence, so if you have already blocked the interferon pathway, then there will be more multiplication of the cells. But again, it's a balance between the productive increase of the cytokines, or the overproduction may lead to complications. So before the adaptive immunity becomes activated, you may block it, so it may be problematic. Adaptive immunity of antiviral B cells, so the antibody mediation and the T cell immune response is responsible for adaptive, and if you are suppressing it, it may lead to antibody mediated responses bind to the free particle in order to block or they prevent increase the clearance of the virus. T cell division of adaptive immunity may be important in resolution of the virus, possibly because the cytokine storm which happens, which may be required, and we have to suppress it. And the T cells are needed for recognizing and destroying the COVID-2 infected cells, and the coordination with the whole machinery of inflammatory response cells. But again, the overshoot, the balance should be important, and the overshoot of the inflammatory response could lead to organ damage, and which were worried in the second half of the viral infection, and either a cytokine storm or a hyperinflammation. So you all know that the whenever you do any transplant, we are worried about the antigen presentation, how the response of the body to any foreign antigen. There will be antigen presentation and the antigen recognition, and then it is given to the cells where it gets represented, and it will lead to a cascade of events. So calcineurin pathway, and also it will lead to the nuclear, and the IL-2 increases, and then which can be blocked by the basiliximab and the Emcure also. So we have multiple drugs which are acting at different levels. The cyclosporin or the tacrolimus acting at the calcineurin pathway, and the IL-2 is blocked by the basiliximab, sirolimus or everolimus, and the drugs, the multiplication, proliferation is also blocked by the azathioprine, MMF, antimetabolites at this stage. And the drugs like all the lysis, T cell and B cell depleters, also they're like an ATG and alemtuzumab, which are also playing an important role in reducing the immunosuppression. We all know that nowadays we have used multiple drug combinations like corticosteroids, calcineurin, and an MMF. Previously, we used azathioprine, which is now a slate. We all know that the drug, the glucocorticoid, acts by the membrane receptor and also by the non-membrane mechanisms, or the delayed genomic response. So the membrane, it leads to the rapid genomic effects, and the delay is because of the transmission of COX-2 transmission and decreasing the inflammatory response. It causes, again, annexes. So basically, it causes anti-inflammation, antipyrexia, and so it's a multiple things. Anti-allergy, immunosuppression, anti-inflammatory, and decreases the permeability. But again, we all know that these are all the multiple side effects of steroids. So the anti-inflammatory and an immunomodulatory role of inhibition of the synthesis of the pro-inflammatory cytokines and decreasing the trafficking and apoptosis of the T cells has all been documented. And this is the only dependable drug in the second half of the infection when the inflammatory cytokines start going up. So this all leads to decrease in the inflammation and decreases the NO. Prostanoids also it reduces, and the additional molecule reduces to reduce emigration, and it reduces the apoptosis. So all these things which will lead to the protective effect of the steroid, again, is the activated T lymphocytes. They all increase the interferon and it attacks the virus. But again, the problem is the dysregulated, when you use corticosteroids, they lead to reduction in the viral clearance. So they may have more and more viruses, and virus gets delayed. The over and very, very increased in the ILF, IL-6, and TNF, and all these things will lead to an alveolar hemorrhage or cytokine-related dysregulation. So corticosteroid may benefit here. So in the second, when they're already an activation of the corticosteroids, they are beneficial. In the early, we should not increase it in the early. So the pathogens, again, you know, the cyclosporin or tacrolimus which are used. So the cyclosporin or the FK, they block the dysregulation, the hypoxia reduces, and also they reduce the mitochondrial stress. So they are useful, and also the cytokines are reduced by the things. So the tacrolimus, it acts on the FKBP, calcineurin, so reduces the nucleophile kappa B, and the transcription of the IL-2 reduces, and which is also an inflammatory marker. So cyclosporin, it acts on the cyclophilin, and the coronavirus multiplication is also reduced. So the multiple viruses, even the BK and the hepatitis C, and also the corona, it reduces, and it also reduces the cytopathic effects in the dose-dependent manner. Even the tacrolimus also inhibits the lymphocyte activation, but again, the more potency of the viral infection, the more potency of the virus is because of the cyclosporin as compared to the tacrolimus. So it reduces the lymphocyte, and it reduces all the cytokines, and also the B lymphocyte inhibition of the T cells, and the granulocyte, calcium-dependent exocytosis also happens. We know the Emcure, which is also another part and parcel of some patients. We use it. It acts in multiple sites. So the hyperactive reduction in the T regulatory cells they predispose to the infection. So the increase in the Tregs, they may help in the eliminating the virus. So, and the viral multiplication is also reduced by the mTOR blockade. And also the immune response dysregulation leading to cytokine storm is reduced. But again, well said and done, it's an anti-proliferative agent. And nowadays, the thing is to stop the anti-proliferative if you have 3 drugs on board, including steroid and calcineurin and also the mTOR. So mTOR should be reduced because more and more, if you have a lung injury, it can per se cause a lung injury. And if you already have a lung injury, then this drug has to be stopped. Otherwise, you may have a beneficial effect earlier in the course of the disease if you are in a moderate dose. MMF or the azathioprine, MMF suppresses the DNA synthesis and proliferation of the T and B cells. It also shown to have some antiviral properties, and it inhibits the SARS-CoV-2 replication in the Vero cells and stem cells. But the cytopathic effect was still observed. So it won't suppress the cytopathic effects of the SARS-CoV-2. So it effectively inhibits the proteolytic activity via acting for the papain-like responsible and cleavage for the non-structural proteins. Hence, the virus maturation is lowered. But even though when it's in the small doses, it does the beneficial effect, but the mean viral load in the lungs was higher in those patients or animals or controls which are treated with MMF. So that is the reason we are stopping the MMF early in the course of disease, earlier in the detection, or we are reducing the dose so that we can reduce the viral copies and curtail the disease at the early stage. So one of the induction therapies what we use is anti-CD20 or a basiliximab. It's used, so the single dose or a multiple doses after 48 hours is used. It's basically, it blocks the activated T cells and activated only, no wide ranging of the immunosuppression, and it can be used. Tacrolimus was another humanized antibody. So the how to prevent this COVID infection in the transplant patients. First and foremost, you all know that the hand washing and coughing etiquette, and also don't touch the face and stay more than 3 feet apart. And if you feel sick, stay home and prevent the spread, or go to the hospital if it is more problematic. So do not change. If anybody in the transplant patient gets it, he is more prone to get early disease because he's immunosuppressed. He may have a diabetes or hypertension or a kidney failure also in the later stages of the disease. So one is you need to get it checked, confirmed, and the cytokines is to be whether to, in those patients who don't have a COVID, whether to reduce the immunosuppression, please don't do that. And changing the immunosuppression, you may predispose to the rejections. If the patient gets a rejection, then you have to over immunosuppress the patient. So do not change your immunosuppression medication, and according to the doses what is required and the range, you need to maintain it so that you prevent rejections. Avoid travel in absolutely, if it is necessary, travel it, otherwise don't. Contact your transplant physician if the patient gets COVID, or you can do the telemedicine if there is no problem, and you can continue the medication. So all these immunosuppression increases the COVID chances, and the morbidity mortality increases, whether to continue on dialysis. This was the paper which was published earlier, and those who have underwent a transplant and those who are continuing on the waiting list, they were compared. So 146 transplant patients, they had COVID with a prevalence of 0.32 as compared to 73% patients who had COVID, and those who are waiting for a transplant from March. So the prevalence was 0.86. That means that those patients who are dialysis, they go 3 times a week to the hospital for 4 hours and they're exposed, and they get more prevalence of getting a higher chance of getting a COVID infection. So they are at a higher risk. And if you see the comparison, what is the death rate? It's slightly higher in those who have dialysis patients as compared to those who have a non-transplant. So 20 versus 26, it is an early report. Now this number of mortality has also reduced. ICU admissions was higher, and the hospital, otherwise hospital admission percentage was higher in transplant patients. This is another paper in JASN, which was published, 59 patients who had an end-stage renal disease. Among them, 2 were on PD and other 57 on HD, median age of 63 years. And if you see the death, 31% died within a median of 6 days after hospitalization. So symptomatically, they had 49% had a fever, 39 had a cough and a dyspnea. So the discharge was there in 69 patients, and patients died who are older age, higher admission and WBC count and CRP. So it's a high mortality in dialysis as compared to you saw in transplant patients. Another paper in 2020 by the Lombardi or Italian group, which has 643 dialysis patients. The risk factor for an ARDS was fever, ischemic heart disease, and also more than 70 years of age. This year, death was fever, CRP more than 50, and a cough. If you see those who have a symptomatic and then virals were given, and 5% had an ARDS and 8% died. And the 79% of the patients were an antiviral hydroxychloroquine glucocorticoid. So 79 patients among this had an ARDS and 42% of the people died. So variable disease severity and the infection of the hemodialysis patients, the high number of patients, they go for ARDS and then they die. So it's a high progression and there's a more chance that these people go into ARDS. This is the paper from Mumbai, and 37 patients on COVID had a hemodialysis patients had a COVID, and the predominant comorbidities were diabetes, high blood pressure, cardiac disease, and if you see 38% of patients died. So it is a very high things leading to mortality. What was the implications that the natures which was published by the multiple people, they said that it may favor in the transplant able to the TAC and MMF potential effects of viral. CNI may be combined with an MMF, basically cyclosporin. It may have a less availability of MMF and a less lymphopenia. And non-immunosuppressive like an immunomodulatory or a plasmapheresis or an IVIG can be considered if you have to intensify the immunosuppression, and the convalescent plasma may be exchanged. So it may favor of an basiliximab as compared to an ATG or alemtuzumab to reduce the lymphopenia. What was the other guideline said? The NOTO said the use of induction therapy or an immunosuppression drug should be based on the immune stratification based on the pre-COVID era. So all these patients, we need to have a mild or moderate risks. You can go ahead. The severe risk, if you have to over-intensify and they have a lymphopenia, they may contract the virus and they may have a more severe disease. So best is to reduce the over-immunosuppression. And if there is severely risk or a high risk, then whether to wait till the disease comes under control. So what is the impact of immunosuppression and the low CD3 or CD8 count? So Alekini et al. He said that infection transplant patients have a low CD3, CD4, and CD8 counts, and which will lead to clinical progression to in a general population. So although these comorbidities are also, and the induction and the virus also reduces the CD3, CD4, and the lymphopenia it causes, the T cell depleting agents rather than basiliximab should be lowered down, and the low immunological risk transplant should be done. And but again, if the patients you have not given, if desire requires an ATG or important immunosuppression you are not given, then the dose of the ATG requirement is higher. As an induction therapy, you may end up giving 2.5 to 3 milligram per kg, but if there is any rejection, you may give it to 5 or more than that also people may require. So this is the chart which shows that the peripheral T cells, if they are higher, and then they have a less viral load as compared to less peripheral T cells, the viral load and inflammation disease severity is much, much higher. Even the CD8 becomes the markers are also significantly higher, and the GSF, IL-6 interferon, they are also higher, and the Tregs will be reduced. So decrease the potential T cell associated severity it may be. So lower end things, they have a rapid clinical progression, and low C3 counts, they need the immunosuppression agents, especially you may have to reduce it. And the early mortality has been also seen in COVID-19 as 28% in 3 weeks as compared to the general population. So very high lymphopenia, they have more and more mortality. What is the outside in the European or the US, what is the practice? The ATG was reduced, the dose from 3.16 to 3.16. What we used is basically in 2019, 47% we used ATG and 15% basiliximab and 31% no induction therapy. We used around 31 patients. We have reduced in some patients where we can't use it, and the basiliximab is 11%, and more of the almost 49% we did it without any immunosuppression. Rituximab used because we had an APO incompatible transplant. So how to go ahead? What are the changes we need to do it? We need to epidemiologically visit is the need transplant, is the need visiting an area. Again, every area now is COVID, and so you have to have, is there any symptomatic disease? Is there any resolution of the symptom it happened? And the repeat testing we need to be done in a disease donor transplant. So this is a COVID negative, and is also both are negative. PCR is negative and the no test. So then they are low risk, and the immediate risk is if they had already PCR negative and not available for test. These things are the intermediate risk. High is already positive. So in a living donor situation also, the same thing happens. If the patient had a COVID and then you have to stop, we need to wait till the all the screening has to be done. I'll come to that, how we did it. So donation of the airborne and the contact in the general population and also the hospital, you have to segregate these patients, and even the OPD, even after the transplant, you have a separate or a telemedicine to follow these patients. What we did is social distancing for almost 15 days, and then the history of clinical examination, is there any potential disease, and they did the PCR and the chest and admitted them 4 days. And we, if there is any chest lesion, we repeated the swab. If there is 2 negative, then if there is no chest disease, and then if they went for a donation. Similarly, if there is nothing and if there is any CT and the swab is negative, then admitted them and started the immunosuppression. If there is a suspicion as a CT or a swab, then we reevaluated them after 2 to 3 weeks, and once negative, and after 1 month we transplanted them again. So if there is nothing, we started the immunosuppression and then went ahead with the transplant. So 3 of the patients we had to stop it, and 1 patient had COVID positive in the donor, and we need to do it after 1 week. So 5 weeks after that we did it. So this was the number of transplant we did in 2019. It was almost a 50%. We stopped all this thing activity in April, and then slowly picked up. But again, it's a 50% activity as compared to the 2019. So what are the requirements for the pre-transplant? Is basically recommend a routine lab of COVID-19 PCR on the airway or for both, and the recipient of the donor has to be there. The test should be done around 24 to 72 hours. In the living donor and also the deceased donor, especially a tracheal swab is better. And so chest scan should be done in the donor is mandatory, and also we do routinely for all our patients. And the chest should be transplant, then it has to be must. And the living donor should not donate if they have a severe disease for 3 to 6 months. The anesthesia guideline says that if it is mild disease, 4 weeks, and if it is moderate disease, 6 weeks, and 8 to 12 weeks if there is a severe disease. And if the patient has significant lung problem, then we have to take again an opinion fitness of the surgery. If there is a saving for the COVID donor, 2 negativity is better rather than 1 negativity, at least 24 hours apart, if there is any suspicion, or should be done after the resolution of the symptoms. General precautions is must for everyone, and minimizing the use of procedures. Induction, if it is an unnecessary, should not be used. And the immunological strategy, according to that, we need to do the immunosuppression, restricting the movement of the recipient to the hospital area where you can have contact with other people, and designated the diagnostic possibility. So the equipments, if there is a designated or at the time, has to be designated for evaluation of these patients. COVID pathway to separate these patients from the general OPD, limit the visitors, and also even the patients with the healthcare workers who have symptoms should be segregated and should be evaluated. Social distancing and the mask is a must. So special informed consent has to be taken during the pandemic, because they already know they can get infection. Nobody knows. We have to think that everybody is positive, and the symptomatic patients should be totally segregated and checked. So the patient and the family should be given information about the COVID-19 pandemic. Most of the people are know risk and the implication of their developing transplantation during the thing, and the written information should be taken, and then we need to proceed. What should we do if the patient gets COVID after the transplant? Is the timeline of the transplant, baseline graft, prior history of rejection has to be taken into consideration in controlling infection and the managing the graft. So the EDTA, they had a recommendation: if asymptomatic patient, no knowledge of COVID, no preemptive reduction in the immunosuppression medications. If there is asymptomatic swab, if the patient has the high propensity for progression like diabetes, cardiac surgery, BMI is high, the GFR is low, then stop the azathioprine, MMF, or an mTOR. If there is a mild disease, then stop the anti-proliferatives. You can continue on the dual, or if they're already on a CNI and MPA, considering replacing with steroids, CNI plus mTOR, and CNI plus steroid. So cautiously restart the immunosuppression after the 3 and 7 days after the symptoms are clear. If there is the moderate disease, if it is first is light, then you may have to stop all, and otherwise then restart with a calcineurin and steroid, and then you back up once the 5 to 15 days of the symptoms have disappeared completely. Usually takes around 2 to 3 weeks for the virus to disappear, and all the serology has become normal, then restart it usually after 3 to 4 weeks. What was the literature? And in COVID-19 in a renal transplant, in a consecutive New York experience, 73 renal transplant patients in April, and 54 COVID positive patients, and 15 were ambulatory and 39 were hospitalized. If you see the outcome, the ambulatory patients, the tacrolimus dose was reduced significantly, and slightly it was reduced, but the MMF dose was reduced in those who are hospitalized, and the adjustment of the steroids was not much, and they are treated with aspirin. And so another is the Belgian experience. They've also stopped it, and they've replaced with the 4 milligram methylprednisolone routine dose continued, and they changed the protocol. So what are the Indian things? So 13 transplant units, 250 transplants.
Maybe 1 minute more.
Yeah, sure. And they had the transplant within 43 years. The common comorbidity is 94%, and the immunosuppression strategy was reduction in the immunosuppression. The outcome was 11.6% mortality, actually 19%. So the more patients who are in ICU on a ventilator, they died. So 50 patients were on home therapy. So how many patients you can get it? So 42% of the transplant recipient, they were positive without significant sputum when you do an antigen testing. So some of the patients may have an asymptomatic disease, so which are not picked up. When to restart the immunosuppression is basically it's not clear. And it's resumed that the calcineurin inhibitor dose should be started first, and then MMF, and then you need to back it up. Corticosteroids, the pro-inflammatory cytokine reduction should be started as a first therapy. If there is a triple immunosuppression, then you have giving a methylprednisolone, then start later steroid and the tacrolimus, and then if usually the fever goes away by the 5th day and the resolution happens, so by 15 to 20 days you can start it. To summarize, there is a concern about the discontinue the immunosuppression. It may cause a problem, it may lead to an acute ACR, and the adjustment of the immunosuppression should be very cautious if there are no symptoms or is not infected with COVID. If the patient is the mild and moderate disease, current immunosuppression dosage should be curtailed and the MMA should be reduced. Start the interaction may have in the plasma or plasma concentration, they may have an interaction with the drugs which are using, so we have to be very, very cautious. Low lymphocyte count may be associated with more severe disease. Transplant patients may severely progress, so it has to be very cautious, monitoring, stopping the antimetabolites in the early stages, reduction in the corticosteroids, and then later stages increasing it. Corticosteroids and the other immunosuppressants should be reinitiated as early as possible, outweighing the benefit and the discontinuation. So to summarize, the pre-evaluation should be done for the COVID, and the transplant should be weighed whether there is a risk versus benefit, and then if there is a risk is higher, we need to discuss with the patient, and if there is any better benefit, then we need to proceed, and if it's become a positive, then we need to stop the MMF or an azathioprine, and the NAT should be done at a regular interval, and we need to stop. Thank you very much.
Thank you, Dr. Umapati. I understand the topic was big, the time allotted was a little small. I had several actually comments, but because of want of time, I just wanted to comment on one thing which you mentioned. You showed some evidences where the risk of COVID infection, rate of infection and death, both were higher in dialysis as compared to transplant patients. But yes, I personally feel there will be some element of bias because the transplant patients would be a little healthier than the entire dialysis population, considering the age, the comorbidities like IHG, etc. So one should take this into consideration.